Assalamu alaikum wa rahmatullahi wa barakatuh. Let's move on forward to the topic of cardiac arrhythmias. Yesterday I have discussed an overview, and in overview also I have gone somewhat deep. Today we will discuss each type of arrhythmia with different type of ECGs, and we will decode that ECGs, how to identify arrhythmia with ECGs. So arrhythmia with ECGs we will solve. Before that, we will understand what are the pathogenic mechanisms. As in the previous class they were discussed, but in a very systematic manner we will first discuss briefly what are the pathogenic mechanisms. So there are mainly three mechanisms by which arrhythmias occur. Why the mechanism is important? Because understanding the mechanism is important for the targeted therapy. Okay, that's why it is important. Understanding the mechanism is important for therapeutic purpose. Okay, so there are basically three. Number one is, as we are seeing, abnormal automaticity. Number two is triggered activity, and number three is re-entry circuits. And among these, this is the most common mechanism which is responsible for cardiac arrhythmia. So now coming to number one, it is abnormal automaticity. Remember, this is the pacemaker potential. This is the basement membrane, basement membrane potential. Okay, this is the cardiac action potential. Okay, this is the base. So usually this is phase 1, phase 1, phase 2, phase 3, and this is phase 4. But in case of cardiac pacemaker potential, this phase 2 is absent, phase 1 is not there, phase 1 and 2 are not there, only 0, 3, 4 are there. So 0 is this one, okay, 3 is this one, and 4 is the basement membrane potential of the pacemaker. Okay, abnormal atomicity, enhanced spontaneous phase 4 depolarization. Phase 4 depolarization of pacemaker cells. Pacemaker cells can be in SA node, Purkinje fibers, or some ectopic atrial or ventricular foci, often due to catecholamines, ischemia, electrolyte imbalance. So the pacemaker will fire fast. Enhanced firing of the pacemaker cells is responsible for arrhythmia. So the factors which are responsible for enhanced firing can be catecholamines. For example, in sinus tachycardia, when there is fight, flight, or fear response, catecholamines. So the sympathetic nervous system will drive through the catecholamines, or when you give adrenaline or adrenaline through IV route. Okay. Second is ischemia. When there is ischemia, there can be abnormal automaticity, or when there is electrolyte imbalance. Important electrolytes: potassium, magnesium, and calcium. These three are important electrolytes. Okay, so number one is abnormal automaticity. Number two is triggered activity. This is initiated by after depolarizations. What is after depolarizations? So during the after depolarization, the cell repolarizes. Repolarizes, but due to some impulse, due to some ectopic activity, the depolarization phase will be prolonged in the middle or at the end of the repolarization phase, and when it reaches a threshold, it will generate a arrhythmia. Okay, remember, after depolarization. So after depolarization can be early after depolarization, or they can be at late after depolarization. Just remember this. There are figures in the next page. There you will understand it better. So early after depolarizations, they occur during phase 2 or 3. Phase 2 or 3 of the cardiac action potential. Early after depolarization, phase 2 or 3. Okay, 2 and 3. So example for this is long QT syndrome, QT prolongation. What is QT? QT is nothing but the depolarization phase of the ventricles. So the depolarization phase of the ventricles is prolonged. Repolarization is depolarization. Okay, so that is the mechanism for torsades de pointis. That is early after depolarization. Then comes the delayed after depolarization. They occur after complete repolarization. that is in the phase 4. Example for this is decoxin toxicity and catecholamines. The most important is the re-entry phenomena. So this is the most common mechanism for sustained, remember the word sustained, most common mechanism for sustained tachycardias. So what it requires, what is the mechanism behind that? It requires two pathways with different electrophysiological properties, meaning different conduction velocities with different refractory periods. There should be one side block and a circuit allowing the impulse to loop back and reactivate the tissue. So there will be two pathway, okay, one pathway with different conduction properties. One will be fast, one will be slow, okay, and there will be block in one pathway, so that the impulse when it is coming from here, it also goes here, and it will go like this, and again it will hit back to the atrium, and this will generate a circuit, and until unless this circuit is broken, the arrhythmia will not resolve. So this is important. So which drug, to know the site of this circuit, to know the site of the circuit is important, so that a targeted therapy is planned. So this re-entry can be anatomic or functional. Anatomic meaning there is some tissue which is utilized for re-entry. Functional re-entry is nothing but there is no tissue, but there is functional re-entry, okay. Anatomic re-entry, circuit around a fixed anatomic barrier, for example scar from previous MI, or tricuspid valve in typical atrial flutter from so that circuit can be around the walls, or accessory pathway in atrioventricular tachycardia. So it can be a scar, it can be wall, or it can be accessory pathway. Functional re-entry, there is no fixed barrier, circuit is maintained around a core of refractory tissue. This is believed to the mechanism of atrial fibrillation and ventricular fibrillation. So now we have learned there are three mechanisms. So this figure depicts that. So this is an example for increased spontaneous automaticity. See, this is a pacemaker potential. So when this is phase 0, this is phase 3, and this is phase 4. Due to some for example due to sympathetic overactivity, or due to ischemia, or due to electrolyte imbalance, this phase 0 is pulled backwards and it becomes straight. This light which is there, light colored, light maroon colored, which is there behind this dark color, that shows that it is pulled. I will show here. See, this phase is pulled, it becomes straight. What that means, that it becomes straight? So it means there is acceleration. For example, you are if you are running a car, you press the accelerator, the car will move forwards. So there is acceleration of the generation of impulses from the pacemaker cells or from ectopi, okay. That is the first mechanism, okay. Second mechanism, see, this is phase 0, this is 1, this is 2 plateau, and this is 4. This is an example for early after depolarization. So when the cell is still depolarizing, here due to some drugs commonly which cause QT prolongation, they will cause blockade of potassium channels. So and they will prolong this depolarization phase. So if the threshold reaches, if they reach a somewhat some threshold, so what happens? L-type calcium gated channels will open and there will be generation of arrhythmia like this. This is example for early after depolarization, which occurs in phase 2 or phase 3. This is the phase 3, okay. Early after occurs, okay. This is example for delayed after depolarization. They occur after repolarization. See, due to some reason there is some spike here, okay, but when this spike here, this is a normal spike which will not generate any arrhythmia, but if it reaches a threshold like this up to here, then it will generate a action potential, cardiac action potential, that results in arrhythmia. That is about delayed after depolarization. The fourth one is the re-entry phenomena, which is the most common cause of arrhythmias. Okay, so in after depolarization there is some trigger. Okay, there is some trigger due to which there is arrhythmia, and that when the trigger causes the action, stimulates the cardiac muscles to a threshold that will generate an arrhythmia. Re-entry circuit is the most common. See here, this is a fast pathway, this is a slow pathway, and there is a blockade here. So impulse is coming down and it is going here also, but because of blockade this will not go here and this will continue. Now this is not refractory, so along with going to along with forward conduction, it will conduct backward also, and it will go and hit to the back tissue also, and this will form a circuit. This circuit will give impulse to the downside also, and this forward also and backward also. So that is the re-entry phenomena. We will understand this re-entry. We will understand this re-entry phenomena with some little detail by this diagram. See this. Re-entry can occur when there are two alternative pathways with different conduction properties, such as the AV node and accessory pathway. This is important. This is a very good example for AVRT, atrioventricular re-entry tachycardia. AV node and accessory pathway, or an area of normal and an area of ischemic tissue. In this diagram, pathway A conducts slowly, so this is a slow pathway, and recovers quickly, while pathway B conducts rapidly, so this is the fast pathway, and recovers slowly. Now in sinus rhythm, this is example here, it is there. In sinus rhythm, each impulse passes down both pathways before entering a common distal pathway. So both are passing before entering. So it is conducting slow, it is conducting fast before entering a common pathway. Okay, as the pathways recover at different rates, so here the recovery is fast and here it is slow. Okay, fast pathway has fast recovery, slow pathway has slow recovery. As the pathways recover at different rates, a premature impulse may find pathway A open, this will A open, and B closed. Sorry to say, fast pathway has fast pathway is still in recovery period, and slow pathway is, because it is slow, so it is recovered, refractive period is gone. So premature impulse may find a pathway A open and B closed, as it is shown here. In this third diagram, pathway B may recover while the premature impulse is traveling selectively down pathway A. The impulse can then travel retrogradely up pathway B, setting up a closed loop or re-entry circuit. This may initiate a tachycardia that continues until the circuit is interrupted by a change in conduction rates or electrical depolarization. Like this it happens. Okay, so because this is a slow pathway and this recovers fast, this will go like this. Okay, this will go like this and backward, and this will become a circuit. That can be an anatomical entry or functional re-entry. Okay, this I have drawn to just to know the site of generation of different type of arrhythmias, so that it is easy to understand. See, just to revise, SVT has sinus tachycardia and non-sinus tachycardia. In non-sinus tachycardia, you will have AVNRT, AVRT, atrial tachycardia, atrial flutter also you can take. Okay. Okay, in irregular, you will have atrial fibrillation, and also you can take in irregular premature atrial contractions. This is SVT, regular and irregular. And wide complex tachycardia, in regular you have monomorphic VT and SVT with aberrancy. SVT with aberrancy. If it is irregular, then it is polymorphic ventricular tachycardia. Okay, polymorphic ventricular tachycardia, or it can be premature ventricular contraction. That's all. See here, in this figure, first, this is AV nodal re-entrant tachycardia. So the loop, the re-entry circuit is situated in the AV node itself. The re-entry circuit is situated in the AV node itself. So drugs which block the AV node will help resolve this tachycardia. Okay. Now AVRT. So AVRT will have one accessory pathway and AV node. So the circuit will be like this. So again, the drugs which block the AV node, or by catheter ablation of this accessory pathway, you can resolve this atrioventricular re-entry tachycardia. Okay. In atrial tachycardia, there are some ectopi foci which are generated here in atrial tachycardia, and they are conducted towards the AV node. So our main goal in atrial tachycardias, or atrial fibrillation, if you take atrial tachycardia, atrial fibrillation, or atrial flutter, all these originate from atrium. Okay. So they send a large number of impulses, for example 200 or 300 impulses. If the ventricles take all the impulses, they will not be able to pump blood. Cardiac output will be very much reduced. So the person will collapse at that site only. So the main goal is to block this number of impulses. Okay, reduce the rate of these impulses. So again, any drug which acts on AV node will help us to maintain the ventricular rate normal, so that the ventricles fill properly and they pump the blood adequately, so that the vital organs are perfused. That is the main goal here. Premature atrial contractions. So after SA node, some tissue of atria will generate an impulse, that is premature atrial contraction. Now see, this is the ventricular side. So example for this is premature ventricular contraction. Now in PVC, these beta blockers, the drugs which adenosine will not work. Adenosine, verapamil, diltiazem, all this will not work. Okay. And ventricular tachycardia, they will originate from this ventricles. Ventricular fibrillation, Torsades D point is QT prolongation. So in QT prolongation, what you will do? In QT prolongation, you will give drugs which reduce this QT prolongation. Okay, Torsades D point is. So this regional diagram is important to remember also, and to understand the therapy also. Now we will move on to each arrhythmia, and we will look out the different ECGs. So first, detailed classification of the arrhythmias. See, this is supraventricular arrhythmias. So supraventricular premature beats, nothing but premature atrial contractions. If you take, for example, premature atrial contractions, as I discussed in previous class, supraventricular arrhythmias originate above the bundle of His. So they can originate from AV node also, they can either, or from any region of atria also. Okay. So take an example of premature atrial contraction. They can be in bigeminy, trigeminy. Bigeminy means every alternate beat will be a premature atrial contraction. Okay. Trigeminy means every third beat will be a premature atrial contraction. Now there will be three phases of this. There will be three phases of this atrial contraction, premature atrial contraction. What are the three phases? See here. This is the T wave. This is P wave. This is P wave. This is the QRS complex, and this is the normal T wave, which is superimposed by a premature atrial contraction upon the T wave, and it is not conducted. Not conducted means it is not followed by a QRS complex. Okay, so that is an example for blocked premature atrial contraction. Next, coming to the conducted premature atrial contraction. See here, this is again a P wave followed by a QRS complex. Here the T wave is, see, superimposed by another P wave of premature atrial contraction, which is immediately followed by another QRS complex, and it will have a T wave which is inverted T wave. So this is an example of conducted premature atrial contraction. Remember, when there is a premature atrial contraction, so there will be a compensatory pause. Why there will be a compensatory pause? The refractory period will be prolonged, and during the premature atrial contraction, the ventricles are not filled adequately with blood. So at the with that beat of premature contraction, the ventricle will contract not strong, and they will pump less blood. But the beat which follows that premature atrial contraction will have a long period, no, because of that compensatory pause. So the ventricles will be filled with more blood, and according to Starling's law, if the ventricles are stressed more, the more powerful will be the heartbeat. So first beat, when there is a premature contraction, whether it be atrial premature contraction or ventricular premature contraction, it will be perceived by the person as a skipped beat. Then the followed by a thumping beat, strong beat, because the ventricles are getting time to fill with more blood, so they will pump that beat with a strong force. Okay, that is how they perceive skip beat and thump beat. That's the mechanism of that. Okay, this is an example of conducted PSC. Conducted PSC with aberrancy. What that means? PSC is conducted, but there is aberrancy. Means with right bundle branch block, or with LBBB, or with some accessory pathway. See, this is again a P wave, normal P wave, QRS complex, and here it is a T wave, but that is superimposed by a PAC, and that is followed by a premature atrial, followed by a different QRS complex, which is not similar to the previous QRS complex. Okay, that is an example of conducted PSC with aberrancy. So PSC can be block PSC, that can be conducted PSC. Example for this is here, and it can be conducted with aberrancy. The QRS complex is different because the path taken by the PSC is different. Whenever the ventricles are stimulated by a different path from the regular path, the QRS complex will be different. Okay, these are the three fates of PSA. Now we will move on towards the supraventricular tachycardia. Okay, so more than 100 beats per minute originating above the bundle of his. Key types are AVNRT, AVRT. AVRT often associated with an accessory pathway, nothing but WPW syndrome, and atrial tachycardia. Now first we will discuss about AVNRT. Okay, see here. In most of the cases, the P waves is hidden in the QRS complex. In cases of AVNRT, you will not see any P wave here. In most of the cases, the P waves is, so most of the typical AVNRT slow fast pathway, okay, the P wave will be hidden in the QRS complex. This is one thing. Or the second and third thing which is there is, and remember always to see the rhythm, you see either the lead 2 or lead V1. These two are known as the rhythm strips. Okay, this second one is, the P wave is sometimes seen after the QRS complex. It will present itself as pseudo S in lead 2 and pseudo R in lead 1. See, this is R pseudo R or pseudo S in lead 1. This is in 90% of cases it will be like this only. Okay, in lead 2 it will be present as pseudo S, and in lead V1 it will present as pseudo R. Okay, why that happens? Because the impulse will, after stimulating the ventricles downside, immediately the impulse rounds up and stimulate the atria also. So because of stimulation of ventricles, you will get the QRS complex, followed by just after giving impulse to the ventricles, the impulse goes and stimulates again the atria. That's why you will have this P wave like this, abnormal, in the lead 2 or R dash pattern. Okay, pseudo R dash pattern like this. Just after the QRS complex, you are getting the abnormal P wave in the form of R dash or S wave, small S wave, because of this mechanism. So 90% of the cases, AVNRT will have this type of ECG. Atypical AVNRT, in 10% of cases, the P wave will occur just before the QRS complex, and it will be, see, it is inverted. It is not typical normal P wave. Just before the QRS complex, you are seeing the P wave. Now this is an example for WPW AVRT. This whole chart is describing AVRT with accessory pathway, AVRT, except to this one. This is AV nodal reentrant tachycardia. So the circuit is in AV node only. See, there is a fast pathway here, there is a fast pathway, and here there is a slow pathway that will generate a circuit. Okay, so that will cause, see here, this is supraventricular AVNRT. You are not seeing P waves, they are submerged in the, this is T wave actually, this is T wave, this is T wave, not P wave. Not seeing any P waves only. The P waves are submerged in the QRS complex, and these things are P waves, T waves, not P waves. These are T waves. These things you are seeing, no? These things, minute, this one. These are P waves. So that is AVNRT. 90% of the cases, the P waves will be submerged. Now, these all things are nothing but AVRT. Okay. So in sinus rhythm, this is the SA node, this is the AV node, this is the accessory pathway. So the impulse is traveling both through the accessory pathway and through the AV node. Okay. So what will happen? The impulse will travel fast through the accessory pathway and it will activate the QRS complex. Okay. In sinus rhythm, the ventricles are depolarized through AV node and accessory pathway, producing an ECG with a short PR interval and broadened QRS complexes. The characteristic slurring of the upstroke of the QRS complex is known as delta wave. The degree of pre-excitation, the proportion of activation passing down the accessory pathway, and therefore the ECG appearances may vary a lot, and at times the ECG can look normal also. So the characteristic pitch, and this is known as, so when there is accessory pathway and the patient is in sinus rhythm, then it is called as concealed AVRT. Okay, see here, this is the P wave and the PR interval is reduced, and there is slurring of R wave, upstroke of R wave, slurring of upstroke of R wave, that is known as delta wave. Okay, this is concealed pattern of AVRT. Now coming to the orthodromic tachycardia. This is known as Wolff-Parkinson-White syndrome. This is manifest pattern. This is not sinus rhythm. Okay, that means a patient which has accessory pathway can be in sinus rhythm. Okay, in sinus rhythm, what is the clue? You will have short PR interval and delta wave. In manifest form, either you can have orthodromic conduction or antidromic conduction. This CV is showing is the this C is the most common form of tachycardia in Wolff-Parkinson-White syndrome. The re-entry circuit passes antegradally through the AV node and retrogradely through the accessory pathway. The ventricles are therefore depolarized in the normal eye, producing a narrow complex tachycardia that is indistinguishable from other forms of supraventricular tachycardia. So this is orthodromic conduction. So circuit will be like this. Because this accessory pathway is acting as a slow pathway and this is acting as a fast pathway, the ventricles are stimulated by the normal wiring. That's why the QRS complexes will be short, but you will not see a P wave. That is a characteristic feature of SVT, supraventricular tachycardia, that will be submerged in somewhere in the QRS complex. Okay, this is SVT. This is also SVT. This is also SVT, but the mechanisms are different. This is AVNRT. This is AVRT. Now, Wolff-Parkinson-White syndrome with atrial fibrillation. In this rhythm, the ventricles are largely depolarized through the accessory pathway, producing an irregular, broad complex tachycardia that is often more rapid than the example shown. So because the ventricles, there is atrial fibrillation here. Along with atrial fibrillation, there is accessory pathway. It can be there, along with atrial AF with accessory pathway. This is an example for AF with accessory pathway. So what is happening? Instead of conducting through the AV node, these impulses from the atrial fibrillation from the different circuits in AF are conducted fast through the accessory pathway. So that will cause, because the ventricles are activated abnormally, they will have broad complex and high rate, very much increased heart rate. Okay, the complexes will be like this. You're not seeing any P wave here. Okay, and these complexes look like this is an example for SVT with aberrancy. SVT is nothing but AF with aberrancy. This is an example for AF with, AF with aberrancy. AF with aberrancy. Now this is not in distinguish. You cannot distinguish this from what do you call ventricular tachycardia. That's the main challenge in broad complex tachycardia which we face, whether it is ventricular tachycardia or SVT with aberrancy. So that was about AVRT. Now coming to the atrial tachycardia. See, every P wave is followed by the QRS complex. Every P wave is followed by the QRS complex, but the P wave is inverted. So that P wave is not from the normal SI node, it is from some ectopic foci. So this is nothing but monomorphic, and it is tachycardia more than 100 per minute. Monomorphic atrial tachycardia, example for this. And see here, this P wave is different, this P wave is different, this P wave is different, but the rate is increased. So this is ECG example for polymorphic atrial tachycardia. Coming to atrial fibrillation, see the ECGs of atrial fibrillation. Again, P wave will be absent. There are multiple minute re-entry circuits, and the atria will be just fibrillating. They're not pumping the blood. So all the impulses are not. There is no accessory pathway. This is AF without accessory pathway. Okay. So AF, all the impulses are not conducted by the AV node. Okay. So see here, you will have a P wave. Okay. But remember, fibrillary waves are not the hallmark of AF. The hallmark of AF is narrow complex tachycardia with irregular interval. Irregular interval. This is the hallmark of atrial fibrillation. Narrow complex tachycardia with irregular interval. Whether you have the fibrillary waves or you don't have the fibrillary waves. Okay. See here, the RR interval is not equal. Okay. Some is short, some is long. Okay. And see here, this is also an example for atrial fibrillation. This is example for recent atrial fibrillation, recent AF, and this is example for what do you call chronic AF. Here the rate is somewhat, if you calculate it 2.5 by 300 means 5 by 2, 200, 5 4 is 2.5, 5 by 2, 2, 3, 600, 600 by 5, somewhat 120 beats per minute. Here the rate is. Again here irregular interval, but the rate is not calculated by the normal 300 by the number of boxes between the RR interval in atrial fibrillation, because the interval is regular. It is calculated by 6-second method or 10-second method. What is that we will discuss in when we are discussing specific tachycardia arrhythmia. Okay, at that time 6-second method and 10-second method. Here you see this is second type of AF. You are not seeing the much fibrillary waves in between. Okay, but here are seeing fibrillary waves in between. So the QRS complexes are irregular and there are no P waves in the A. There is usually a fast ventricular rate between 120 and 160 per minute at the onset of atrial fibrillation. In chronic atrial fibrillation, the ventricular rate may be much slower due to the effects of medication and AV nodal fatigue. You are giving medications, that's why these fibrillary waves are blocked. No, they are blocked. That's why you're not seeing those things. Same thing in some other. This is from Oxford. Now you can see the fibrillary waves, and these are not normal fibrillary waves. These are fibrillary waves. Okay. So this is an example for recent atrial fibrillation that indicates this innovation. Now no fibrillary waves. So this is chronic atrial fibrillation. How you identify? You look at the RR interval. They are irregular and the QRS are narrow. That is the hallmark. So this is known as fine atrial fibrillation. Sorry, this is known as coarse atrial fibrillation, and this is known as fine atrial fibrillation. Fine atrial fibrillation is nothing but chronic. Coarse atrial fibrillation is nothing but acute, recent. Okay, then moving on to atrial flutter. Now you see in atrial flutter there is the rate will be like this, some 250 to 300, 350 in atrial flutter. Every P wave is followed by a QRS complex. Every P wave is followed by a QRS complex. This is the P wave, P wave, P wave, P wave, P wave, P wave, and this is the QRS complex. R wave, R wave, R wave. That means the AV node is conducting every impulse which is coming to it to the ventricles. This is a very life-threatening form of flutter AF, and it is very rare also. Most commonly 2:1 and 3:1 are common. Every every second or third impulse is conducted. So example for that is this one. See here, this is P wave followed by QRS complex. Now again this is missed. This is the second P wave, QRS complex. Now first P wave is missed. This is the second P wave followed by QRS complex. Again the first P wave is missed. This is the second P wave followed by QRS complex. First P wave is missed. This is the second P wave followed by QRS complex. So every second P wave is followed by QRS complexes. 2:1 conduction. Atrial flutter, but you are not able to differentiate this one. Okay, this is narrow complex regular tachycardia. Okay, but whether it is AVNRT or AVRT, we are not able to differentiate it. So what you are giving, see here, you give adenosine 6 mg. After giving adenosine to 6 mg to this is happening. So you are blocking the AV node again. You are increasing the resistance of the AV node. So again the conduction impulses from the atria are reduced very much. Now very much they are reduced. So that's why after giving adenosine you are now knowing, see, this is the atrial flutter, this is sawtooth appearance. So after giving adenosine you have diagnosed that it was atrial flutter. So that's how adenosine helps us in differentiating different types of supraventricular tachycardia and also in treatment also. Okay, so I think it is enough for today. We will discuss ventricular arrhythmias and investigations and flow charts, how to approach in detail. The first one is the simplified chart, so one can follow that chart also. That is very easy to follow. Next flow charts which are coming are detailed discussion about this SVT and VT, pinpointing AVNRT, whether it is AVRT or something like that. Okay, thank you for your listening.